is a live stream with the hospital. It's a great honor for me to announce the lecture by Professor Gérard Giraudon on left atrial isolation. And this is part of the cardiovascular grand round in the University Hospital in Maastricht. I'm extremely happy to announce Professor Giraudon because he is one of the founders of surgery for cardiac arrhythmia, which is quite special because that was not an easy area to start in. And today we honor him for that matter by shamelessly putting him to work here in the cardiovascular grand round by asking him to present on right atrial isolation, 30 years in the waiting. And this, as I said, presentation is broadcasted also to the audience in cardiology in the Maastricht University Hospital. Dr. Giraudon is a renowned international cardiac surgeon, and he's a pioneer in the field, as I said, having perfected many life-saving, now standard surgical procedures, and especially then also in cardiac arrhythmias. He was born in Paris. He can't help it. It's not his fault, he says. And he graduated from medical school there, and he worked at the Salpêtrière Hospital, performing the first human cardiac transplant there in 1968. And he pioneered the research and implementation of surgical procedures to correct cardiac arrhythmias. Eventually, he went to Canada, Western Ontario University in 1982 to serve as a chair of cardiothoracic surgery. And in 1996, he moved to Buffalo in the United States, where he also served as chair of cardiothoracic surgery. Dr. Giraudon received many awards. It's a long list. I name a few. Among them are the NASP, it's now HRS, the NASP Distinguished Scientist Award in 1996. And in 2004, Queen Beatrix, then Queen Beatrix of the Netherlands, appointed him as a knight in the Order of the Dutch Lion, which is a tremendous distinction, a distinction only given to people with exceptional achievements. Dr. Giraudon published hundreds of scientific papers to make public his inventions. Among all inventions in surgery, there are the Giraudon incision. I heard it's still used today, every day, by especially arrhythmia surgeons. The corridor operation, not in use anymore, for treatment of atrial fibrillation, but also the illustrious Giraudon Universal Cardiac Introducer. If you abbreviate that, that's the GUCCI. For accessing the left atrium for catheter-based ablation. That's for patients with resistant atrial arrhythmias. And he also pioneered, for many years now, decades, ultrasound-based augmented reality image guidance during off-pump mitral valve replacement. Despite all his grand achievements, Dr. Giraudon has always remained a modest man. That's how I know you, Gérard. A very modest man. And that's also, in fact, how he approaches a clinical problem, respecting nature, being modest about the possibilities of a surgeon, never giving up on a patient, that's very important for him, but also respecting and listening to other professionals, especially cardiologists. You know, you have to sometimes listen to these people. It's always to learn and to teach. It's always learning and teaching. That's how he, and that's, in fact, is his secret. And that's how he could invent new surgeries for treating arrhythmias and cooperate so effectively with people around him. In the Netherlands, his home was Nieuwegein, right? So with Jo de Vouw and Norbert van Hemel, you cooperated a lot, and with many others. And well, that was always big fun, also to meet you there. That's where I got to know you. It's my pleasure to invite you now here and come up to the podium and teach us about right atrial isolation. Professor Giraudon.
myself, my old guy, I have to be seated, so I see you better. And when I move the stuff, yeah.
You can move this, and you can look there for yourself.
Okay. Okay, they have an ambulance if something happens.
Yeah,
so.
we call an ambulance. A few slides there.
Yeah. So the first slide is one of my masters. This is the guy that tell me that before doing anything, you have to think about it. That just means that well, if you have an idea, think for years before using it. And he have another stuff, I love it. When he was giving a talk, he was pissing off people. When I push now, oh, here. And for the talk, I never give a talk like this, but it's just for the morning. I will talk in three parts. The first part is the missed opportunity. I thought we were almost right for the corridor, but I could not convince people that I was right. That was proving that I was right if I cannot prove people. The second is that if you cannot convince people what to do in electrophysiology, why not to try to say, why not instead of want to stop the tachycardia, why not to want to restore normal physiology? Because after all, this may be what we should do. And the number three is that it's a dumb operation now. You have two little bundles that you have to cut, and you do the operation. And that's not a good sell, because people want to make it complicated in order that they feel better. So the corridor story is an interesting story, because when we started the corridor, we knew about nothing about cardiac physiology. We were not even sure if the right atrium was better than the left. Oh, I'm sorry, I have to do this. Okay, now. We would, it's not good for me. But I cannot read it. Oh, okay, I will try. I will try. A great actor can die on the spot, so I may do that to them. The history is very simple. We have done a lot of stuff already, and we were not doing AF. So I said, we have to do something for AF. Why? There was no good reason at the time. AF was, at that time, we have already the two concepts, exclusion and you put me in this 12 fancy situation. Okay, the rational. What we knew about atrial fibrillation, at that time, it was supposed to be a benign disease in the 70s. In the 30s, it was dramatic. So it was, why you want to do something? Because I have to stop them all. The mechanism was probably re-entered, and we have a special surface that in order it can work into it. So we came to a very stupid idea. Why not to have a kind of a band of atrial tissue, which is not big enough in order it can fibrillate, and small enough in order it can conduct. And we call it a corridor. Why not? And at that time, we thought it was interesting to do it because people were sometimes symptomatic, but they were not sick. Now, you realize that this is a beautiful drawing to explain to you how we do the corridor. And if you want to sell an operation like this, You have to be a genius. I was not a genius. I couldn't sell an operation, so stupid, with cut everywhere. But if you could do it, it worked. What do we learn of the corridor? First of all, we discovered that the coronary sinus was an interatrial connection. That's critical. We missed the Bachmann bundle. That was stupid. We confirmed essentially that the atrium was tubing, elastic tubing. And what I say, conducting tubing is critical, because most of the cardiologists I know, and sometimes are excellent, you know, they teach me. When we say contraction for an atrium, we say no, the contraction is a side effect of conduction. The timing of the contraction is for conduction. So it's a side effect, but it works wonderful. You never had block between the SA node and AV node. So it's something, but when people see a tube contract, they feel it's a pump, no? When a tube contract, what happens? It's shorter, it's straightened, and sometimes the flow is faster. So this is a fundamental. If you don't understand that, you read the heart wrong. And this is a patient, and you can see the little blip is gone. But when you see the little blip, you feel contraction. No, you see velocity, no change in flow. It's just a little bump of pressure. And what we needed at that time, we needed two discrete targets and understand the physiology. But it's interesting enough that when we in Ottawa, because people keep keeping me out because they're fed up with Giraudon. So I was in Ottawa those times. When they described the bundle, nobody mentions it was so what. And such a wonderful piece of equipment. So now, this is the one I work most on it. Asking the right question. Restoring normal physiology. The first thing for you as a cardiologist, you have to be a fan on the heart. The heart is not a pump. It's an insult. It's a very sophisticated system that produces mechanical work. If you look at a pump, you will never understand the heart. And because you don't understand, it will never tell you how beautiful it is. And complex. If it were a pump cannot be complex. But something that mimics a pump with a brain and everything can be complex. So the first intelligent question to ask to you is that what, after all, are all the chambers equal? Equal in function and in nuisance. So you say, right atrium critical, pacing. The ventricle, it does all the job mechanically and intelligently. Now, the right ventricle, it's a tube. And the left atrium, this is the worst. Not only does it do a good job, but it's high on nuisance. High on nuisance. Every misery comes from the left atrium. I'm not a leftist myself, but we know it's just happened on the left side. So, right atrium, in 1981, we just get rid of it. and put it back. And now you realize that he's happy. He can beat as fast as he can in his little corner, and the rest of the heart is just fine. That was pretty. I can understand why I do that operation, but it was so much fun. And now the fundamentals. I hate that slide, and I like that slide. Why? Because once again, with our brain, we want to cut pieces. It's one unit. Oh, no, it's not one unit. You have the pacing system. You have the mitral valve and left ventricle unit. You have the contraction and the elastic tissue. You have the flushing. And most people laugh when I say the heart flushes itself. And the brain. Without a brain, the heart cannot work. And the chronotropic system is critical, as you know. First of all, it's very safe until it gets into the heart, the ventricle. But for the atrium, now you understand that the connection between SA node and AV node is pretty safe. It picked the earliest activation right on the papillary muscle. And most of the drawings that you do for your student, you put at the apex. No. Papillary muscle is closing the mitral valve first. So he activates the left ventricle at the middle. And the ventricle is a pressure chamber. You realize that the middle is a great place to do. So, number one. And the right is done by a bunch of Scots. And we can see that right on the papillary muscle. The first guy, which is a Canadian, that described that electrophysiology, the papillary muscle at first, he was a real electrophysiologist. He had no clue that was to close the mitral valve. It's the reason I do function today, because sometimes the function, you don't like it. But it's beautiful stuff. And now, the mitral valve and the ventricle. You cannot have a ventricle without a mitral valve, and a mitral valve without a ventricle. This is impossible. By the way, it's thousands of years together. The problem with mitral valve, and like the doctor feels this is the mitral valve. This is one of the little things. It's part of it. And you can see as well that the McAlpine, it didn't show you the mitral valve annulus because there is no annulus. And there's a lot of variety, but it still works because the activation is right. And you have to have a brain to adjust for this. Now, this is how works the mitral valve. You realize you have the left ventricle, the papillary muscle, the chordae tendineae, the valve, and look carefully here. You see that it's just a little fold. So they can do this thousands of times a day without breaking. If you were an annulus, it would break right away. And in normal heart, you have two papillary muscles, and all those loops go through two. But if you have thousands, it works. This is the way it works. Thanks God, We don't have to know how it works to fix it. This is a terrible drawing, but what it shows very well is that the motion of the heart is minimum. The mitral valve, just a little bit, the thickening. The epicardial doesn't work. That means that the structure is never changed. This is not some, when people say the heart works like this, it's criminal. So the ejection fraction, it's interesting. I'm going to show it to you now. When you look now at the heart, it's funny, I'm missing a slide. If you give me the orifice, I can build the heart now. Because that distance, oh, I see what happened. When I can go back?
In the red button. It's the red button.
That just means that because I show you that it doesn't move, you always have that volume in the mitral valve going to stay. So the ejection fraction is right here. That means that every number you look at the heart is in harmony with the rest. And when I see people drawing the heart with a big bulge in front of the mitral valve, it's foolish. A contraction now, mechanical power. The contraction does a lot of stuff for the heart. First of all, it opens and closes the mitral valve. I mean, it closes the mitral valve. It sickens the myocardium. And when it sickens the myocardium, it is going to distend the elastic network. And during diastole, you have the recall. That just means that there is more elastic tissue in the myocardium than myocells. And as usual, if you ask a question, what is most important, elasticity or contractibility? It says they are equal. If there's no elastic, it doesn't work. If there's no contraction, it doesn't work. And the LV flushes the left atrium. It flushes itself, but it flushes the left atrium. So the critical role of elasticity, every engineer knows that. The aorta, without elasticity, doesn't work. The left ventricle, no elasticity, it doesn't work. And for LA, elasticity facilitated the flushing because you need a recall. So if you ask, it's critical. And the massage cardiac, when people massage the heart, if they were not elastic, when the elasticity is dead, you say the myocardium is dead. Elastic for sure. The myocyte, I'm not sure. Now, the story of elasticity is very interesting for me. Shannon Blake had been a master in cardiac physiology. But he knew the cardiologists. He knew you guys, they say. If I want to sell elasticity for the cardiologist, no way. He picked Scientific American to publish one of the most critical papers on cardiac physiology. You realize how we stand? Those guys would not believe it. It's This is just to show you again the perfect harmony when it moves, and the economy of motion doesn't move a little bit. Why? Because you know that the anatomy is critical, so it can move but don't destroy the system, and it does it very well. And the epicardial volume does not change. It's a plus. And if you want to know it doesn't change, you just take any paper and they show you that. But it's a paper with Michel et Saguer. And I understand. I understand my mistake. You don't know? Oh. I need a doctor. So you can see that stuff doesn't move. And it's a good paper. By the way, he was a pneumologist. I don't know why he wanted to document that it move. That means that the stuff is always perfectly inserted. Flushing. As far as I'm concerned, I'm the first fool that tried to sell flushing in the circulation. I came to recognize that that feature has been totally ignored. And it gave a dramatic concept of flushing. If you don't flush, the system is going to clot. And it's clear that what left appendage, what you need is flushing. And it can be flushed perfectly. I mean, perfectly. When you see the bastard, you know it cannot be flushed perfectly. But sometimes it does. So when you take the plane, you take an anticoagulation, flush. So there is a story. In life, if you don't talk to people, you don't learn anything. And I was in Spain with Carlos Duran, and we are finished early because with the system you can have a second case, so we went to the playa. And the beauty in Spain that everybody talks to everybody, even in Spanish. So yeah, a bunch of guys, I go there. How are you? Where are you? What are you doing? I'm an engineer. Huh? What an engineer does here? Say, we keep the sand on the playa. Hey, what are you? We are cardiac surgeon, huh? What kind of cardiac surgeon you are? Carlos, his Spanish better, he say, I'm interested in the aortic valve. Huh? In valve? How it is? Carlos said, well, there's three stuff, and there's a little leaflet, and within second, the engineer says, that's it? Well, that's it. And Carlos says, oh, the coronary artery, where they are? Huh? How many? 2. But it would be better with 3. The first question for the aorta, and you look at the aorta, you say, if you put blood and then you leave it, something would happen. So once again, the God, they flush during diastole, but they are flush. So why we don't think about it? So the goal is to make sure that the blood doesn't stay more than a beat in any cavity. Simple. The LA is an elastic conduit. This is a plus for flushing. But 2 critical mechanisms are involved. The left ventricular suction, diastole, and the left atrial recall. So we have documented for each, by the way, the beauty is you just have to read the literature and make the calculation that your friend, the guy I didn't do. They don't give you the stroke volume, but they do the other thing. And you realize that for 5 publications, this is equal within a cc. For the paper from Michel is 19 cc. For the LA, it's 100 cc for the stroke volume. It works absolutely fantastic. And how it works? Once again, elasticity. The elasticity done a big suction for the left atrium, and the elasticity of the left atrium give you the recall, and you flush. That just means that, and I will do that later, when I tell you all those numbers, you realize that there's a real harmony in the system. That if you have an aorta, you get almost the left ventricle. If you have the left ventricle, you get the right, you get the left atrium. Every of those measurements and flow and everything are one. This is not an accident. It works wonderful like this. So every time it's too big, too small, it doesn't work. I mean, it doesn't work. It doesn't work perfectly. It doesn't mean that you do clot systematically. So I have to put my name somewhere, and I put my name in the toilet. Oh, what he does, Gerard, he's flushing. It's a tough job. So normally it's one, and it gives you probably an idea when you start to look at it, is that how bad the flushing is and how good the flushing is. But it works for every patient. That just means that the left atrium doesn't need to be sinus reason to be flushing, which is good for. This is good. No reason to have LA dirty because it doesn't defibrillate. And for the left ventricle, it works wonderful. Not only it was wonderful, but it overdo it because the stroke volume is much greater than the diastolic volume. And the first thing it does when it fills in is to push the stuff. So the flushing, and there's something in the ventricle which is intelligent, is a trabeculation. The trabeculation, sometimes they can remove the little clots that start to form and push them out. So essentially, all the blood moves perfectly, the same volume moving, and there's no stasis or stuff like this. Little brain and the heart. This is the most critical part of the talk. If you don't feel the heart as a brain, you can't understand the brain. The problem is that most people are pissed off because the heart is smarter than the cardiologist. That's life. And he knows everything. And I have a story for you. This is a story of when we are cutting the heart in two, right side, left side. And in our patient and in our dog, when we were resynchronizing the two, on that beat, the DPDT of the left ventricle was up. So the same beat, within milliseconds, the guy said, I was waiting for this one. So it's a good example of the brain. It's react within milliseconds. The problem is it's a heart cells. But nobody likes intelligent people, as you know, so they don't like a heart. I like that slide because you realize that if you take a fly, they have 2 neurons. The heart, he has thousands of neurons. So he has enough. This is the brain. This is the brain. And he knows everything. And I'm not sure that I don't think he listens to the cardiologist, but he listens to the heart. So back to square one. Left atrial physiology. The flushing is critical. And you can flush whatever the atrium contract, blah, blah, blah. The contraction doesn't do much about flushing, by the way. The LV must be in sinus rhythm with a good diastolic function. And now we put really a good test on atrial contract. It has really to suck. The elastic recall is critical because this is the suction. And the stroke volume and the pre-diastolic volume of the LA must be equal. But God took care of this. So, conclusion is that if the left atrium is isolated, what's going on? Nothing. Everything as usual. But the nuisance of LA is on. So the LA now can play game, fibrillate, right? But hey, we know that guy. But now you're in cage. Well, what we need? I like that drawing, by the way, it's mine. Because I make sure that it can't do. Sometimes we don't know if it can't do. Now you can see it goes in. Just this. It's beautiful. This is a Bachmann. He asked me to cut, so I have more Bachmann to show you, but this one. And it can be dissected and cut, whatever. The coronary sinus bundle. This is, and I have to shoot a wrong done by our colleague, a histologist. Colette parted them. They describe a left-sided of the shit. I need an assistant. Okay, that's beautiful. And they describe this going to the left side. I marry a pathologist, so I know sometimes they screw up. No, it goes posterior. So they describe a AV node left atrium connection. And you and I, we are looking for that damn connection. One day with my friend in Utrecht, we thought we have seen one, probably it was. So it does not exist. So there's 2 connections for the atrium, the Bachmann bundle and the and we Colette after that did a lot of work for us. We have about 10 heart, and we never find that left stuff. So if you want to do the array isolation, I'm not sure I've convinced you, but at least remember my name. It should be okay. I hate to conclude, because in my life, I don't want a conclusion. But what kind of intervention can be good for a cardiologist? or some physiologist, or you have two discrete. This is nasty. Because so far, we don't have to win to be a good ablator. But here, if it's discrete, if you miss, it's your fault. I know it's unfair, but you restore two imperative functions: normal physiology of the LV and the flushing of the system. So the optimal result, they want function and harmony. So do it as soon as possible. If you're already a big LA or something, it probably may, with time, recover. But it's so essentially, you could ask people to have a left atrial isolation at birth, and you'll be happy for your life. Thank you so much to listen to me.
Thank you very much. Very interesting lecture and a very interesting view on the heart as a toilet. So flushing the left atrium, for instance, is very important, and it's something we are not used to look at. We usually describe the heart as something which contracts, and cardiologists, they usually talk about a good function of the heart if the ejection fraction is okay, forgetting about that the heart has a diastolic function. So I found the concept that you divide the stroke volume by the left, so the end diastolic, the pre-diastolic left atrial volume. That's quite interesting, because it makes you think of how much the atrium is flushed as soon as the heart
but
relaxes.
You know, it's hard to convince people when we are right. It's very tough. No, it's interesting for me because, first of all, I never presented a talk like, I mean, this talk. I have to do it because they are friends. And even if I may fool myself, I would enjoy it. I never talk because they say, no, Gerard, you cannot stand, so I have to sit down now. So essentially, I'm discovering that after all, to talk seated, this is fantastic. And thank you for listening.
Okay, thanks very much. We enjoyed it. Thank you.
I could see, I did not piss anybody in the room, so I should do better next time.
Not yet. Okay.